Okay, so let's move on to the last speaker before we have the oral expert presentation. Hans, Dimosthenopoulos. You will talk about diabetes-specific nutritional formulas for prevention of hyperglycemia in the intensive care unit. Please keep to 20 minutes max. Thanks.
Okay, Eugene. Thank you very much. I'm going to discuss about the diabetes-specific nutritional formulas that they can be used for the prevention of hyperglycemia in the ICU. All of us, we know. Oops. Can I see the slides here? Okay. All of us, we know that nutrition is very important for the ICU patients. It's important in total, but in general, and more specifically for the patients in ICU, there are many cases and many reasons why we need the good nutrition. And that's because every ICU patient is at risk of malnutrition, and the regional screening for malnutrition is really important. So in order to decide about the nutritional approach, we have to think about many things, and we have to monitor, we have to estimate, we have to use GLIM or other tests in order to realize if we have malnutrition. But as far as concerned the hyperglycemia, we know that it's a big percentage, 22 to 46 of hospitalized patients that are they have hyperglycemia taking enteral or parenteral nutrition. There are many predisposing factors that they include the age, they include the presence of diabetes, they include the infections, and we know that hyperglycemia related to nutrition support is associated with an increase in mortality and morbidity. We have different guidelines, but today we will based on the ESPEN, the latest ESPEN guidelines on clinical nutrition in the intensive care unit. We know that the medical nutrition therapy should be considered for all patients staying in the ICU, mainly for the first 48 hours. We have to make all the to give all the recommendations in order to provide the right nutrition to these patients, and we have to decide about early medical nutrition with enteral or parenteral nutrition. Mainly, we have to decide about the energy and the protein targets that we have to focus and we have to provide to the patients. And the hyperglycemia occurs frequently due to stress, induced glucose intolerance, pre-existing diabetes mellitus, or the use of glucocorticoid therapy. Management of hyperglycemia often involves exogenous insulin, and the observed increase in mortality associated with the induced hyperglycemia provides a strong incentive to explore managing the hyperglycemia with a reduced dependency on insulin. Here we have the different guidelines in ICU or non-ICU in order to how to measure and how to focus on the hyperglycemia from different associations. And we know that the insulin regime is related with the kind of the type of feeding that we provide to the patients. So let's see what are these diabetes-specific nutritional formulas. Here is a comparison, a table which compares the content of the standard feeding, where you can see that we have a high percentage of carbohydrates, 55%. We have a high percentage of lipids, 30 to 35, and a medium percentage of protein, 15 to 20. And here we have the comparison with the diabetes-specific formula. Here you can see that we have a lower percentage of carbohydrates, 30 to 40, from isomaltose, oligosaccharides, and fructose. And also we have the content of 10 to 15 grams of dietary fiber. We have a higher percentage of lipids, 40 to 50, and mainly we have monounsaturated fatty acids. And also we have a higher percentage of protein, 15 to 35, in order to avoid, to prevent, and also to treat sarcopenia and malnutrition. And here there are some regimes. We have some formulas that we have in the USA. I use this table in order to see the different percentages of the basic macronutrients. And this is a table of the ones that we have in Europe. And it's a slide that Jeffrey presented, saying that the diabetes-specific formulas are usually lower in carbohydrate, as we've seen before, and have a modified type of carbohydrate and higher fat content. Their effect on gastric emptying have not been confirmed in the critically ill. So let's see some studies focusing on the use of these specific formulas. What we want to do, of course, we want to have lower spikes. So using this special formula, mainly due to the content of macronutrients and the presence of the fiber, we have a slowly digested carbohydrate energy in comparison with the standard formula where we have a more rapidly digested carbohydrate energy. We begin with the use of diabetes-specific formula in non-ICU patients, just to see that it's something that we are really interested in. And this is a study using this diabetes-specific formula high in monounsaturated fats. And this showed that this meta-analysis shows that this specific oral supplement, same tube feeds, high in monounsaturated, can improve glucose control and metabolic risk factors among the patients with diabetes, or just with straight-induced hyperglycemia, comparing with the standard tube feeding. Let's begin with the ASPEN. These are the guidelines of 2013. During these guidelines, they were saying that there is no need to use the diabetic-specific formula, that there is no recommendation that can be made regarding the use of this diabetes-specific formula for enteral-related hyperglycemia. Some years after, we have the guidelines of ESPEN in 2023 that they give an opposite opinion. They say that the amount of glucose and carbohydrate in enteral and parenteral feeding administered to ICU patients should not exceed 5 milligrams per kilo. And the main point is that the use of diabetic-specific enteral formula in the ICU patients suffering from type 2 diabetes seem to improve the glucose profile and may have clinical and economic impact. So we can see that there is a change of the opinion about the use of these formulas, and they give an advice about the content of lipids. During critical illness, we know that hyperglycemia is prevalent. It is associated with adverse outcomes. And while treating hyperglycemia with insulin, reduces morbidity and mortality. It increases glycemic variability and hypoglycemia risk, both of which have been associated with increase in mortality. So we know that nutrition forms part of standard care, but the carbohydrate load of these formulas has the potential to exacerbate hyperglycemia. For this reason, specific diabetic formulas with a lesser proportion of carbohydrate, as we've seen before, which are available, and these formulas are postulated to limit glycemic excursions and reduce patients' requirements of exogenous insulin. So in this study that they use, then they compare a diabetes-specific formula versus a standard formula. They showed that at present, modification of the composition of enteral nutrition is rarely considered to be an efficacious mode of therapy for glucose control, despite its significant contribution to total carbohydrate intake. In another study where they compared the glycemic effects of a low carbohydrate enteral formula compared with the enteral formula of standard composition, we can see that the low caloric formula gave lower mean glucose measured per point of care device, and also the same type of feeding patients required significantly less insulin on second study day. Also, in this study, where we had, again, a comparison between diabetes-specific formula feeding in comparison with another one high in protein, we can see that this high-protein diabetes-specific formula showed a lower mean glycemic variability versus control, and also the intervention showed lower mean blood glucose compared to control. Finally, from this study of 2019, which is a practice guidelines of enteral nutrition, they show again that the glycemic target specialist nutrition and low in glycemic index and glycemic load and containing optimal protein, they focus also on protein except from carbohydrate, is important for nutritional management of these glycemic critical ill patients. So apart from the carbohydrates, we have to focus also, that we saw that in the previous presentations, on protein. We know that critically ill patients experience substantial loss of muscle mass, muscle strength, and recovery of muscle strength after discharge of ICU. For this reason, we know that in the ICU, after the ICU admission, muscle and fat mass is in danger. We know that most of the people lose a lot of their muscle mass during their stay in the ICU. And also we know that the muscle mass loss in the ICU patients depend on the severity. For this reason, these specific formulas have another good point that they have to provide to the patients. They have the high intake of protein. Here we have a comparison of two different specialized diabetes formulas, high or higher in protein, and they are compared with a standard formula, high in protein. The main findings from this study was that the less insulin required for the specialized formulas high in protein, lower glycemic variability we had also with these formulas, and also with one of them that it was very high in protein, but also low in carbohydrates, fewer hypoglycemic events were presented. So the conclusion of this study is that compared with the high protein standard enteral formula, a high protein diabetes specific formula reduced insulin requirements, glucose variability, and plasma and capillary glycemia in mechanically ventilated hyperglycemic ICU patients. So we need the extra protein, we need less carbohydrates in order to treat our patients. But in the case that we cannot use the enteral feeding, we have the use of parenteral nutrition. In this case, of course, we have high levels of hyperglycemia in these patients, but in this case, we don't have specific formulas. In this case, we have just to adjust the insulin regime that the patients take according to the volume of parenteral nutrition that they take. And of course, we need a team. We need the diabetic doctor, we need dietitians, we need also the pharmacist, but also we can use the technology. The CGMs can help in order to see the peaks, the glucose peaks, and adjust the right insulin to the regime. And here we have the summary of recommendations for the management of PN hyperglycemia. And finally, apart from the nutritional aspect, we have the economic aspect, which is really important. We know that the budget that is given for the health is very low. So it's very important to also think about the economic aspect of using this special feeding. This is a very interesting study that it was on this point, on this at the clinical and economic impact of the use of diabetes-specific formula. Here we have again the comparison between a specific formula for diabetes and a non-specific formula. And we've seen that first of all, we had a lower mortality rate in diabetes-specific formula. The length of stay, which is really important in ICU, was 2 days, which is really important, shorter for diabetes-specific formula versus non-specific formula. The lower insulin prescription rate at ICU admission and at discharge with the diabetes-specific formula. And finally, we have lower in total ICU costs, which is really important, as we said, and we know. So we know, and that we take these findings that they highlight that the importance of adopting diabetes-specific formula as the enteral formula for ICU patients with type 2 diabetes, and they also underscore the need for further research in order to generate supporting evidence regarding glycemic control with growing population in need of diabetic management globally. So, here we have the conclusions. We know, and we really know that the nutritional formula have the capacity to influence blood glucose control during critical illness. Despite this, only, as we've seen, only a small number of studies have investigated the effect of manipulating nutritional formula on blood glucose control in intensive care unit setting. So critical ill patients experience marked changes in carbohydrate metabolism, which contributes to hyperglycemia. Acute hyperglycemia is associated with various adverse outcomes, including increased infection complications, prolonged intensive care unit, which is really important, at hospital stay, and increased risk of mortality. So the final conclusion is that the use of this specific formula in the ICU patients with type 2 diabetes is correlated with a significant reduction in mortality and improved health economic outcomes. And finally, we realized that diabetes-specific formula with lower carbohydrate content has shown to be attenuate hyperglycemia and decrease glycemic variability in the non-acute setting. So there is the need of using these formulas, of course, whenever we have them in the pharmacist of the hospital. And with this, I would like to thank you.